I'm going to discuss a little bit on the pathophysiology of stimulants and stimulant use disorder. I'll kind of touch briefly on each class a bit within the stimulant class itself, and then as I mentioned, we'll kind of discuss some treatment approaches such as like psychotherapy, and then we'll kind of touch more on the medication management. And then lastly, I wanted to discuss special populations, specifically those with ADHD and previous stimulant use disorder, and how we treat these individuals when they come to your office. I apologize if my voice cuts out. I'm getting over a cold, so I just got my voice back. So bear with me on this. So some of the stimulants that we all know of the classes are like cocaine, amphetamines. Our amphetamines are broken down to our prescription ones. These are like our ADHD meds. These are the diet aids, both by prescription over the counter. Then you have your methamphetamine class, and this is actually a Schedule II substance, Schedule II in the fact that we actually do have a prescription available for it. It's called Disoxin. I've seen it prescribed once my entire medical career. Otherwise, it's very rarely prescribed. And then there's other modified amphetamines. There's other stimulants like cat or bath salts, of course, caffeine, nicotine, and then stimulant chemicals and like over-the-counter products like our ephedrine, pseudoephedrine, things in our cold medicines. Pseudoephedrine now obviously is locked up or with the pharmacists due to the Combat Methamphetamine Epidemic Act of 2005, where they removed that from all of the over-the-counter products to limit the use of production of methamphetamine. And I won't really get into this today, but there's mixed results on whether or not this was truly effective and whether or not this was the right act to do. And then MDMA, I'm not going to discuss in detail today, but I wanted to just briefly mention it here as it does act as both a stimulant and a psychedelic. So just a little bit more details about each one. Cocaine, it's naturally derived. It's cocaine based is what we kind of all know as crack. People mention crack. That's kind of where it originally comes from as the base. It looks like a regular kind of small white rocks. And right there, kind of at the bottom picture, it's in a base form. It produces this very intense euphoria producing stimulant. It's short-lived, but it's the rush and the onset are quite quick. And also that comes with that is tolerance usually builds up pretty quickly, and then there's generally a significant crash. Some common names: crack, crank, flake, rock, snow, soda cat. I think that's supposed to be cat, blow, coca, and then coke. And it's generally snorted or dissolved in water and injected. And when it's smoked, that's where we get the name as crack cocaine. So our amphetamines, as I mentioned, we have the prescription ones that would be like our Adderall or Vyvanse, ones that we would generally use for ADHD. And then we'd have our methamphetamine. And as I mentioned before, there is a prescription for it, and the only use would be for ADHD as well. And methamphetamine is also typically taken orally injected. When you add ice to it, that's when you get that crystallized methamphetamine, and that's when you would get the inhalation route. And at the bottom is, you see the kind of the pipe. That's what you would use to actually use the ice form of it. I also I put a picture of the powdered form, and then above, that's the typical Disoxin prescription. If that was ever going to be prescribed for somebody with severe ADHD not responding to other stimulants, it would generally start at 5 milligrams. Some common names for amphetamines, specifically methamphetamines: Bennies, Black Beauties, Crank, Ice, Speed, Uppers, some that you probably heard. Methamphetamine is actually similar to cocaine, but much slower onset and a much longer duration. Chronic use of methamphetamine generally produces a psychosis that resembles schizophrenia. You'll generally see paranoia, hallucinations, and then the violent and erratic behavior, which I'm sure a lot of you all have experienced in your guys' practice. And lastly, just briefly touch on CAD, which is also stimulant. It comes from a flowering evergreen shrub. It's typically taken by chewing on it like tobacco, and it's then kind of retained in the cheek, and then throughout the day they can kind of chew on it a little bit more to get the release of that stimulant drug to kind of get the stimulant effect. As I mentioned, there's two active ingredients. That's the caffeine and the cathinone. And some of the side effects that you may notice if somebody's actually using this is they'll kind of get that brown staining of the teeth. They'll complain of insomnia, gastric disorders, and then this physical exhaustion that they will often complain of, especially with chronic use. And then similar symptoms that can happen with overuse is delusions, paranoia, nightmares, and hyperactivity. Let me okay. So how do stimulants work? What is it about stimulants that make it so difficult to treat? And when it comes to any type of addictive drug, it all comes down to basic biochemistry here in our reward pathway. So all drugs of abuse will target the pleasure center of how we get the release of dopamine. So even food has a similar mechanism of creating that enjoyment, and the reason why you kind of want to go back to like sugary things or candy or sweets, or just food in general gives you that kind of reward pathway. And so there's kind of a picture kind of showing the difference how food can produce that euphoria from dopamine. And then obviously cocaine produces at a much higher threshold. So with this addiction pathway, you're going to get an inhibition of both dopamine and norepinephrine reuptake. And then certain substances also potentiate the dopamine release. And so it's kind of a twofold effect, and you generally get that with our amphetamines, our methamphetamines, which are the two I mainly will discuss today. So this kind of gives it a better visual. This might give somebody kind of some heart palpitations going way back to biochemistry and neurology, kind of looking at the neurotransmitters, the transporters, things like that. But it's a really good visual to show where these substances actually act on the neurons within the brain. And so, we have the synapse here, and if for most of our amphetamines, we're going to get the blocking of that reuptake. So we're going to get the neurotransmitter that will stay in the synapse, so they'll be able to produce the stimulant effect, and they'll be able to do that for an ongoing duration, forever, how long it lasts. And then up here is where we get more of our stronger amphetamines, and like methamphetamine, we're actually going to get that release of it as well. So it's got that twofold effect. So when we think about stimulant use disorder, and somebody comes into your office and this is a concern, or they're presenting with their complaints or just symptoms that you've noticed, one of the first things before even kind of going towards the if it's a stimulant use or if it's a substance use in general, first thing is you want to identify any substance use disorder. And so if we want to identify stimulant use disorder, you first need to confirm the diagnosis and then, of course, characterize it. And so this will be solely based on the patient's report initially, and then you will use your screening tools, collateral information, the signs and symptoms that you're noticing, and then toxicology, and all of that will kind of come together to give the diagnosis and then the characteristics associated with that diagnosis. So in order to give somebody a diagnosis of any substance use, the use must be distressing, and it must cause impairments for this individual. So some of the symptoms that they may have are this persistent desire or unsuccessful efforts to decrease their use, and they have to kind of talk about what of those principles that they did try to actually decrease use. And then the other one is drug cravings when they're not using. Some of the behaviors we typically see with the diagnosis of stimulant use or substance use disorder is increasing amounts of use over a longer period than intended, excessive time obtaining it or recovering from use, failure to fulfill major obligations, whether it's work, family, they're using it despite the consequences that are happening in their life or knowing that they will happen. They'll give up either important activities, or they won't go to maybe like family events or like child games. Maybe they'll forget to pick up their children from school activities. And they'll continue to use despite it being physically harmful to them, whether they're diagnosed with, with heart disease or they had a heart attack, and they continue to kind of use these stimulants, regardless that it will worsen that condition. And so, as I mentioned, the continued use despite knowing all of this information. Some of the physiological changes that we typically see as well is they will generally use more of the substance and develop this tolerance. And on days when they're not using the substance, they'll have those withdrawal side effects. So now we'll get a little bit more, touch more on methamphetamine specifically, and discuss more of the prevalence and the epidemiology regarding methamphetamine use disorder. It has a 4.7% lifetime use. And this data is relatively old. It takes some time to actually update this data. But it had a 0.4% past year prevalence and then 0.2% over the past month. And this has stayed relatively consistent. Recently, in the past couple of years, we're seeing that increase, and I'll kind of show the charts regarding that a little bit later. Amphetamine type stimulants are second most frequently used illicit class in the world. And they're commonly used in the United States for obesity, mood, and ADHD. And the use of those actually peaked in 1967. And then we get this overshadowing effect with the opioid epidemic, but the drastic rise of stimulant use, it has been rising just as fast as opioids. Methamphetamine, it's a mixture of pseudoephedrine and ephedrine. A new manufacturer decreased with reduced pseudoephedrine availability, and that's when we kind of remove that from the cold medicines and substitute it for an ingredient that actually is not as effective. So that's where some of the debate is on whether this was actually helpful for the population. Cost is down in 2007 to about $80 per gram currently. So it's pretty cheap, affordable. Its purity has actually increased over the years. When it was originally on the market many years ago, it was about a 40% purity, and now we're looking at 80%. And a lot of times it's also laced with other substances like fentanyl or other opioids. As I mentioned, available as a powder, crystalline form. It's most common in this area. And then urine detection is typically less than 4 days, but up to 7 days if heavy use. The longest I have seen somebody produce a positive urine drug screen was actually 14 days. Now, whether or not the information that was providing was I hate to use the word the truth, but whether or not they were recalling the true information, that was debatable. The effects of methamphetamine are generally higher if it's smoked, and usually they're immediate if it's smoked or injected. And then it's got this slower onset but longer duration if taken by mouth or intranasally. The past year of methamphetamine use, this was the results of the National Survey on Drug Use and Health from the 2019 study, but it's a good visual to kind of show how the use is steadily rising. And the 18 to 25-year-old age range is generally where we see it, or we're seeing it the highest, and then we kind of get this decrease in 2018, but some of the recent studies that they have done, which I believe I put them in here, show we have that rise again. And as one thing I wanted to point out to this is they generally look at age 12 and above. And so, some of these kids are being exposed at such a young age. And this is when ADHD should be the focus of the conversation. And I'll discuss a little bit more regarding that later on in this talk. So this kind of breaks it down a little bit into certain groups. We have race, age, and sex. And it kind of just shows the steady rise. And this is a little bit more of the updated data, I believe. Oh no, this is the same. I believe I have the next slides will show kind of more of the updated. But you can kind of get a visual how it's gradually increasing over the year. Any methamphetamine, this was with hospital admission, but any methamphetamine reported at the treatment admission was 14% in 2010 to 23% in 2017. And then methamphetamine as the primary substance was 9.4% in 2010 to 14.5% in 2017. So that's a pretty big jump. And we're getting about an average 8.8% growth per year for any meth use, and then about a 7.4% growth for primary meth use. And this has been consistent across nearly all the demographic groups examined and across regions when that they've been doing these studies, that they're seeing this growth increase. And as you can see over here, we're seeing the most prevalence of methamphetamine use is actually in the West. And this is just kind of a different visual if whoever likes to kind of see them stacked and seeing the difference. But at this top is all amphetamine related hospitalization. We're getting this steady rise across the board. So some of the presentation symptoms that we would see when somebody is actively using methamphetamine, we get this kind of drawn and kind of sunken face. We see a weight loss, and that's due from kind of the decreased appetite. They're not really eating. The skin erosions is a textbook sign. Lots of skin picking and from the tactile hallucinations. I know we have a couple dental experts, listening in on these. And so I absolutely wanted to mention some of the dental side effects that we see, but we will get to see some of those mucosal infarcts. We'll see a lot of teeth damage and decay. And we'll generally see worsening of mental health and co-occurring underlying mental health diagnoses, whether depression, anxiety, executive functioning deficits become extremely prominent with chronic use. So perhaps these individuals may have been maybe taking it for self-treating for maybe their concern for ADHD, where you would actually see an increase initially with their executive function, but with long-term use with methamphetamine, we actually see significant deficits in their executive functioning. And then you generally will see those severe urges and cravings. So besides the psychiatric side effects, we also see potent central nervous system stimulation. You get that disinhibition, euphoria, elevation, enhanced sense of self, increased energy, sleep, go for days without needing any sleep. You'll see tachycardia, increased heart rate, increased blood pressure as well. Some of the adverse effects, all of these are kind of adverse effects, but some things that other people will notice around you are anxiety, talkativeness, paranoia, psychosis, and then the stereotypes of the skin picking, as I mentioned. You can get stroke, circulatory failure, you can have even death. And then, as I mentioned before, depression, executive function will worsen, cardiovascular disease potentially will worsen as well. When somebody stops using methamphetamine, the results can be immediate and can last from 2 to 3 weeks, and sometimes actually a lot of times longer than that. But the most distressing symptoms typically last from immediate to 2 weeks. Depression is the most common, and hedonia. Then a lot the secondary symptom we see a lot is fatigue, sleeping throughout the day, and then when they are awake, we get this increased appetite and eating behavior. And this kind of puts it into just a better visual of the overall effects that methamphetamines and stimulants in general have on all aspects of the body and systems. So to touch a little bit more on withdrawal and abstinence, we see some significant changes in the brain when methamphetamine is removed. And as you can kind of see in a healthy person, we get those dopamine areas lighting up appropriately. And that's going to be your red and your green, and from the dopamine to the dopamine transporter, how they're interacting. And then the middle image is somebody that has not used any meth in the past 1 month. You'll see a little bit of that reactivation of the dopamine pathways, but it's significantly diminished compared to a healthy individual. And then 14 months after abstinence, you see that it's really starting to return to baseline. And so that kind of gives you a good visual of how long these people can generally have side effects after they stop methamphetamine, especially if they were chronic users, that it can take years, potentially longer, to actually see the return of the dopamine pathways. Okay. And as I kind of mentioned before, I think that just kind of puts it more in less of a visual and more of the kind of a list out of what we generally see. But we need to, if somebody comes into the clinic or the hospital and they're having active withdrawal symptoms, we're generally going to use supportive treatments, because our current medications aren't great for it, but supportive therapy is generally going to be best. For agitation, benzodiazepines is generally used, or antipsychotics. Usually antipsychotic is the preferred choice. We generally have hallucinations, especially those tactile hallucinations, and antipsychotics can be helpful for that. So now I'll touch a little bit, we'll kind of gradually go into methamphetamine treatment. I'll discuss just a tad on cocaine treatment, and then we'll kind of go back into methamphetamine treatment. But there are similarities between methamphetamine treatment and cocaine use disorder. As I mentioned before, cocaine, we get kind of the faster onset and faster offset, and then methamphetamine is more slower onset, longer duration. Methamphetamine use disorder is actually one of the most difficult substance use disorders to treat. It's difficult to get patients to engage and then remain in the treatment. There's a lot of inpatient management issues, because a lot of times they are going through withdrawals, and we don't have effective treatments to actually manage that. And so a lot of times, especially on inpatient units, they're kind of in the dark. They kind of let them sleep, but then when they're awake, we get a lot of management issues and behavioral issues, especially aggression. Most of the data that we do have on methamphetamine use disorder treatment is psychosocial interventions, such as like a 12-step recovery type program. Cognitive behavioral therapy is helpful. But one of the problems with this, a lot of these individuals do have executive functioning deficits, so it can be very difficult for them to actually engage and remain in treatment. And then, of course, contingency management and time abstinent, and we'll discuss a little bit more on those here briefly, or here shortly. So with some of the psychotherapies, the general approach that we must take when we're treating somebody with methamphetamine use disorder is you want to increase the intensity for higher severity or inadequate response. So if somebody's not producing the response that they may expect or you may not expect, increasing the intensity or increasing whether if they're doing 3 days a week therapy or it's group therapy, then increasing the amount of days and longer duration, and we'll hopefully get a more appropriate response. A lot of these treatments are in the outpatient addictions counseling groups. You can also do intensive outpatient therapy, and this is largely group-based, which can be difficult for a lot of these individuals, especially if there's underlying ADHD, but still it's a very effective treatment. And then, of course, individual therapies plus groups, such as the contingency management and then the CBT. so as somebody's going through these treatments, you always want to assess and then always treat the comorbid psychiatric underlying disorders and other substance use disorders as well, such as opioid use disorder. You would want to discuss any medication-assisted treatments with that as you're doing treatment for methamphetamine use disorder. And this kind of breaks it down just in a little bit better view than what I had before. But so the therapy modules that we kind of talked about, the one thing I wanted to mention is family therapy, especially for our youth. That's going to be incredibly helpful and absolutely necessary. Whole family needs to engage in the treatment for these youth to have a successful treatment. So the pros with these treatment modalities is they are evidence-based. It's the best evidence that we have on treating methamphetamine use disorder. You get that skill building. A lot of them are deficient in these skills, basic life skills, increase in internal motivation, and then the bridge to getting additional treatment. And of course, this can be used in multiple settings, inpatient, outpatient, intensive outpatient, and so on. The cons that will may be difficult for a lot of individuals, it's time limited, resource intensive, limited workforce. I mean, and limited availability as well. There's modest effect sizes within the studies, so applying it across all populations can be difficult, and of course, it's not suitable for everybody. You have to have some basic cognitive requirement in order to be successful in it. And then there's really unclear if there is an ongoing sustained benefit that will come from it with methamphetamine use disorder. So when we look at all of the non-pharmacological treatments, this kind of gives a good summary of what we know about the therapies and what is most helpful. So we know that they are effective in treating methamphetamine use disorder. Contingency management and cognitive behavioral therapy are generally will yield better outcomes per the research that we do have on this. It's dependent on the methodology and the interpretation of the study and being able to kind of apply it to the population that you're looking to use it on. And then and that can cause some major downfalls in our research is there's not really a way to standardize this across all of the studies. And so you kind of just got to take and choose what might apply to maybe your patient or a population that you're treating in, because that's really the best that we have to go off of. Okay. So now we'll go in a little bit more on, we'll switch gears now and discuss the medications that might be helpful. So we're talking about non-pharmacological, and now we'll move to the actual pharmacological side of treating. So we'll first kind of discuss cocaine here, and then we'll move on to methamphetamine. We have a little bit more research on cocaine use disorder. Still not great, but we have more studies that say that certain medications may possibly be helpful. Some of those are like disulfiram, topiramate, and methylphenidate. We find that the evidence shows that there's likely a use reduction associated with these. And additionally, some of the evidence that is proving to be hopeful is the word that I would use is modafinil, memantidine, varenicline, naltrexone, disoxyzin, and to kind of name a few. The ones that we know are ineffective based on what's available today is lithium, carbamazepine, tricyclic antidepressants, SSRIs, we find are actually not helpful. In a few of the studies, we actually found that it's actually harmful, and patients have an increased rate of testing positive for methamphetamine on returns. Bupropion was found to be not effective in cocaine, and antipsychotics and selegiline, and to kind of mention a few there. So the ones that we do know are promising. So as I mentioned, none of the studies that we have on this are great, which is why we don't have any actually FDA approved medications for the treatment of stimulant use disorder, methamphetamine use disorder, cocaine use disorder. Topiramate is a promising one for cocaine use. It is an anti-epileptic. It increases GABA activation, and it may be especially helpful when combined with CBT. And this is, what we generally see with most psychiatric diagnoses, such as like depression. Adding medication with the therapy is generally going to be more helpful. And the one in that's been frequently studied, but the results are inconsistent but still promising, are amphetamine salts. They increase dopamine and norepinephrine availability, which is also what we see with cocaine use. So the idea would be like a substitution therapy like buprenorphine, naloxone, and opioid use. And the results are mixed. It improves with retention potentially. A couple of the studies found that the longer they're on it, the results are generally better. Other studies show that it has to do more with the dose, and that they need higher doses of these amphetamine salts to actually get a decrease in outcomes. And the outcomes is generally always the urine samples on whether or not they are positive for the drug that's being tested. And this kind of puts it in a graph, and it gives a good visual, which is why this is one of the more promising medications for cocaine use disorder. So this was a 12-week trial, 142 people that were dependent on cocaine. The exclusion criteria was severe use, and so this is more of our mild to moderate users. But after that 12-week period, those on the topiramate did find a decrease in the days of not using cocaine. So this is promising. And this kind of puts it, same study, this kind of puts it in just a visual of what some of the results that they actually got. So days of cocaine use during the 12-week study. This is actually the study where they're actually on the amphetamine salt. So the other one was the anti-epileptic, and this actually the amphetamine salt. So I apologize. But even as you can kind of see across between the placebo and the actual medication group, you actually see less days of that cocaine use, 44.9 compared to the placebo, which is 60. And as you look over, it is a significant result. And so this is a promising study. And several other studies have continued to try to reproduce this. And unfortunately, we're not getting that reproducibility across the studies, which is why we don't have it as a approved treatment yet for cocaine use disorder. Now moving on to methamphetamine use disorder. As I mentioned, no accepted treatments as of today. As I mentioned before with cocaine, same thing applies for methamphetamine. There have been many small studies suggesting potential benefit from like mirtazapine and bupropion, but nothing to actually say that this would be a great treatment for actually treating methamphetamine use. We do know that the results are not appropriate for someone to be using naltrexone, amoxicillin, buprenorphine, naloxone, and stimulants. And so we can say that it's either producing results of no change across placebo, or it was actually harmful for people with methamphetamine use. This is the data for one of the studies that looked at mirtazapine as a potential option. And as you can see, it looks promising after 12 weeks of being on the medication. There were less patients in the medication group that were testing positive for methamphetamine. So this is promising. And again, this kind of just puts it into kind of a better visual. And the one thing that I did like about the study specifically is they included individuals that were, how they termed it is light methamphetamine users, and then heavy, severe stimulant use disorder, and mild general is what we would say here. But as you can kind of see in the chart, the top view where we kind of see that decrease in the use is across the ones that had mild methamphetamine use. And then when it doesn't really apply over to the severe methamphetamine use. And so we really get that inconsistency across how much somebody is using or even how long somebody is using. I'll kind of skip that slide. So this kind of puts a good graph into where the studies are going, where the research is going to try to come up with an effective treatment for methamphetamine use disorder and amphetamine use disorder in general. And there's not a lot of studies, unfortunately. So we kind of just have to kind of pick and choose between the studies on what applies to your patients, as I mentioned before, and take some of those findings and use some of these medications potentially off-label for what the research kind of supports here. But stimulants are the most studied one today. Methylphenidate has positive results, and I'll discuss those here briefly. Dexamphetamine and tamoxifen are the ones there too that we're really not seeing any change in methamphetamine urine drug screen positive results with those medications. Topiramate's been the only one that has had any studies that produced possibility that can be helpful, but even that has been inconsistent with methamphetamine use. And with our antidepressants, generally SSRIs do not help, and actually some of the studies have shown that it actually will increase the use and kind of make that worse for patients. So that is not a consideration for treating somebody using SSRIs. So the big question that I often hear in psychiatry, especially in the hospital settings, is, does ADHD, prescription of ADHD with medications, does that impact the development of substance use disorder? And we've had lots of research to support that it does not harm and it does not cause a stimulant use disorder. And so this, with somebody with ADHD and even previous substance use disorder, generally people will need to be treated with ADHD medications, whether it be a stimulant, and that's not going to cause worsening outcomes for them. So some of the research that we do have on it, it's not a lot, and I think that can make a lot of psychiatrists or non-psychiatrists even wary about treating ADHD when there is either ongoing amphetamine use or previous amphetamine use. But the studies that we do have been consistent that there is no difference in the rate of substance use disorder when ADHD is treated. We don't see any worsening of that. So that's a positive, and that's reassurance that people with ADHD should be treated effectively. So one of the main studies that we actually see, excuse me. One of the main studies that we see that we've seen positivity with ADHD and it not causing ongoing substance use or worsening substance use is a study conducted in 2007 where we had adults treated with ADHD and they also had cocaine use disorder at the time. And when they were given a stimulant, it actually decreased the probability of cocaine in urine drug screens. So we actually got a decrease once their ADHD was actually treated. Unfortunately, there was no difference in ADHD symptoms. And so that study had a lot of limitations, but one of the limitations could be the fact that the dose was potentially not increased appropriately. But it's hard to say, but the individuals within the study didn't really get any benefit from the ADHD symptoms. Another thing that could become an issue for a lot of these patients that are on stimulants is they're self-treating their ADHD. And so when a stimulant is started, you're kind of taking over for the the dopamine pathways that are kind of deficient once that stimulant is removed. And so a normal dose that you would typically start an adult on won't have an effect for these individuals. It's kind of just filling in the gaps of when that stimulant was kind of removed. And so a lot of people can be uncomfortable with actually increasing the dose appropriately. And that's kind of what we seen have happened with multiple studies regarding this, including this one. And this kind of just is a better graph. I'm kind of speed through these so you guys can have a chance to ask some questions at the end. But overall, a summary with ADHD, and I don't know if you've all have been in my other lecture on ADHD. ADHD is a major passion of mine, and trying to increase awareness of actually treating these individuals. But overall, what we know about the studies to date is that we don't see any worsening of substance use disorders when we treat their ADHD. So, giving somebody a prescription of Adderall or a stimulant won't cause them to have a stimulant use disorder. It's unclear whether or not we actually get any benefit if somebody has an amphetamine use disorder and you treat and you use a stimulant, prescription stimulant to treat. We just don't have the results have just not been great. It's been pretty inconsistent. Of the ones that we do have available, the stimulant that is the most promising, again, it's still inconsistent, but the one that is most promising would be Ritalin. Or Adderall or Vyvanse. Those have been generally not helpful across the board in the studies that have been done. The only one that has produced some positivity and being promising for the future is Ritalin. So if there was ever a stimulant that if you're kind of designing a patient-specific treatment and you were thinking about adding a stimulant on board off-label, the only one I would really consider at this time for stimulant use disorder would be Ritalin. So just a quick summary of kind of what we talked about. We talked about a little bit of a prevalence of stimulant use disorder, some of the symptoms that we see and the withdrawal symptoms and how we can appropriately manage that. We also discussed the psychotherapies and some of the medications that we have. And again, they're not great. I hope this changes in the future, and I hope we can get some advancements in being able to effectively treat these individuals. And this kind of just gives a brief summary of cocaine and methamphetamine. And remember, always treating the co-occurring mental health diagnoses, and then ADHD is a special population that we generally want to treat at the same time that somebody's being treated for their stimulant use. The last thing I also wanted to mention with ADHD is I want this to be in everybody's mind, kind of if they have patients coming in. Maybe you have a patient in your mind now that you can think of that may have been struggling with this. But ADHD is prevalent in a lot of these individuals that are using stimulants. A lot of them are, maybe have been exposed at an early age, and a lot of them kind of will tell this like microdosing type of self-treatment. And they'll kind of say, it allows me to function. I feel different. I feel normal. I feel like I can do even basic chores that I've never been able to do. And this is incredibly important in how they present this information, because it can kind of guide, maybe looking into ADHD and screening for ADHD. I would highly recommend always screening for ADHD, especially if we have a lot of legal issues, because these individuals, when they're not appropriately treated, as they go into adulthood, we generally see them run into the law a lot of the time, in and out of prison, kind of dabbling in lots of other substances, especially if they haven't had any exposure to stimulants yet. They'll kind of say, I use it all. I could give or take it all. And that's technically true. Where they kind of, if it's available, they'll use it. But once they kind of get that exposure from stimulants, that generally is their substance of choice. And so I want you all to not be scared, to treat ADHD. It can be a very difficult thing to treat and manage that patient population. But if we treat the ADHD and the underlying ADHD, generally it becomes much easier for both you and the patient to actually treat the stimulant use disorder. So just wanted to make that last mention. And if anybody has any questions, I would be glad, and the rest of the team would be glad to answer them. It looks like we have about 5 minutes.
Thanks, Stephanie. Yeah, we have a couple of questions in the chat. I can read the first one here from Mary. She says, I've been seeing more Vyvanse prescribed. What are your thoughts on Vyvanse?
Vyvanse prescribed for ADHD or for stimulant use disorder?
Not sure. She wasn't specific.
Let me try to pull up.
I suspect she means stimulant use disorder.
So Vyvanse, none of the studies that to date have shown Vyvanse to be effective. And the reason for this is Vyvanse generally has a much slower onset. And we get this maximum saturation of the dopamine receptor. So we're not going to actually be able to get that same effect if somebody has a stimulant use disorder. And so, our methamphetamine, cocaine, I mean, they're just much more powerful when it comes to stimulating dopamine. And that's why our medications like Vyvanse especially aren't going to be able to cover it. And so the research kind of across the board on that has shown that Vyvanse is actually not helpful. So if there was a stimulant, as I mentioned, that if I would use off-label for stimulant use disorder, it would be Ritalin. It's the only thing that we had, the research that has been promising for the use of that.
Yeah, she did clarify she meant stimulant use. Question from Shelley. What SUD screening tool do you use?
Can you say that again?
What substance use disorder screening tool do you use?
The ones, it's generally dependent on where I'm at. And so for adolescents, that one's pretty consistent. But for adults, it can really vary across where you're at. And I'm trying to complete blank on the one that I'm currently using.
She did just specify in a hospital setting for adults what SUD screening tool to use in that setting.
Can you sorry.
Oh, sorry. Yeah, she specified she's interested in a screening tool for substance use disorders in a hospital setting for adults.
Like on inpatient settings?
Perhaps. Yes.
Yes.
For so we actually don't, for stimulant use disorder, and I'm trying to think off the top of my head. We actually don't have any specific for stimulant use disorder in the hospital setting. And I might have Todd jump on and correct me if I'm wrong. But on an inpatient setting, I don't think we have actually a specific screening tool. We have them for opioid. I mean, like, cows and withdrawal, it's mainly looking at withdrawal, but for stimulant, no, it really comes down to, as I mentioned, being able to diagnose it and asking all those questions. So I kind of listed them out in that slide where you kind of go through. Those are specific questions that you would ask, and the answers based on those is what would determine if somebody has a stimulant use disorder. So I'd base it more on the diagnostic criteria, and less on the actual screening tool in an inpatient setting.
Couple more questions, it looks like. One from Gina. Did the ADHD studies that you discussed, did they differentiate male versus female patients? Have there been more undiagnosed female patients in life?
I mean, across the board, generally, yeah, it generally takes longer for females to be diagnosed with ADHD. But regarding ADHD itself, there's a 50-50 across female and male prevalence. females are generally diagnosed later, especially in youth, but as they become adults, I mean, we see generally the same difficulties in life, like normal life issues for females and males.
Stephanie, there's a question about using stimulants for ADHD and then having benzodiazepines prescribed. I ran into this a lot of that in my practice as well. Do you have any comments on that?
Yeah, I would say don't do it. You know, because they kind of go against each other when you're actually using them both, and so they're actually not getting the true benefit of the stimulant medication. So whenever and I have a clinic that's kind of just sees ADHD, but in one of my clinics. But when somebody comes in and they are on a benzodiazepine, you know, I make it quite clear to kind of get them off of that and just reassure them that for true ADHD, I mean, if we're not concerned, it's not any other diagnosis. We're truly dealing with ADHD, then their anxiety will actually get better as the stimulant gets to the appropriate dose. And so, you know, a lot of them are very protective of their benzos, don't want to come off of it, but giving that reassurance that their anxiety will actually be a heck of a lot better once we get them on the appropriate dose of the stimulant. And then they generally do really well. I can't think of any patient that has flat out refused to do it and wasn't successful in actually weaning off the benzodiazepine.
If there's another question here. I mean, is there anything then you use for anxiety control in, like, let's say they have underlying anxiety or adding the stimulant does not help? Is there anything you recommend for anxiety? This question is anxiety control during a dentist appointment.
So so two different questions there. So the first question I'll say is the first thing I would look at is did the stimulant you chose potentially make them worse? And so we generally should see their anxiety get better, but you know, everybody doesn't respond the same to stimulants. So say if you started Adderall or Vyvanse, they're not doing well, then I would probably switch over to like the Ritalin class or Concerta. Concerta generally is what I would do for adults if they can handle Ritalin okay. And I would try that first before adding on any additional medication. But giving, you know, like PRN hydroxyzine would be completely appropriate to kind of get them by as they're making that transition. If they continue to have anxiety, even with an appropriate dose, their ADHD symptoms are improved, then, you know, likely they have a co-occurring, maybe generalized anxiety disorder or some anxiety disorder, and you know, choosing SSRI or SNRI for that would be helpful. And then the other question is, what do you recommend for anxiety control during a dentist appointment? Hydroxyzine would be appropriate. But the one medication I probably like the best when it comes to anxiety and especially kind of these panic episodes for people with ADHD is clonidine. Clonidine works exceptionally well. So that would be another medication to kind of keep in your pocket. The other time you can use it is especially for sleep. A lot of these individuals have this delayed sleep onset, can't really turn off their brain. Clonidine will be exceptionally helpful for that as well. So I encourage everybody to always stay away from benzodiazepines. It'll generally make it worse for them, and use medications like clonidine and potentially hydroxyzine.
Thank you.
Yeah.
Looks like we're at the end of our time here. There's a link in the chat for the evaluation survey to grab your certificate. I'll also be emailing that out later this morning. And like I said at the beginning, our next session is a little unique, I think, for us. And it's something we haven't done before. It's going to be all case studies related to alcohol, cannabis, and methamphetamine and other stimulants. So if you have a patient you'd like to present and have the team comment on that, please just let me know. I'll be following up with some emails soliciting those patient discussions. So please just get in touch with me if that's something you'd be interested in participating in. So we hope to see you back in 2 weeks from now for our fourth session of this series. Thank you.
Thanks, everyone.
Thank you, Stephanie. That was very good.
Absolutely.